Thank you, everybody. So let me just preface this initially and just say thanks for coming to the webinar. Obviously, I know you guys have a lot of things you can be doing at 8 o'clock at night, at least 8 o'clock here, Central Standard Time. And I'm not really going to bore you. I just kind of wanted to share some things with you because I'm seeing a lot of, strange procedures being done and some strange removals. And I just kind of wanted to give you a brief history on, who I am, what I'm doing, and why I'm even here. And so I guess basically what I'll start with just to kind of get the ball rolling is I practiced in Tucson about 13 years ago. And in about 2006, I started doing the Essure procedure. Eventually, just like everybody else, I was fairly convinced that, it was a great option because as a gynecologist, we were waiting for years for a method where we could sterilize patients that wanted permanent sterilization without having to make an incision in the abdomen. And, I think that would be awesome, especially since men don't really desire getting vasectomies, which would obviously be the best option. So I think that with good graces and I think with the best of intents, physicians were pretty excited about it and were excited about bringing it to their patients, and I was one of them. I moved to Austin in 2013, and when I moved here, I did an Essure, and the Essure that I did was pretty easy, pretty straightforward, although I will tell you, the lady ended up getting pregnant. And the only reason that I knew that was because she showed up to a doctor in South Carolina and with her pregnancy, and subsequently he called me, which is really unheard of because most of the time doctors don't do that. And when I heard from him, I kind of started thinking, I wonder, how many women get pregnant with this thing, because that was the first one I had ever seen or ever had myself. And so I went online, just like a lot of you all do, and I found the Essure Problems website on Facebook that Angie Firmalino put together, that she started by herself, that now has grown to 31 or 32,000 women, which is completely crazy and wonderful at the same time. But and I know she's put a lot of work into that. When I found her, and Angie Desa will tell you that initially I was probably a fairly big jerk and was very obstinate and very convinced that all of these problems were not coming from the Essure coils, just like probably many of you have heard time and time again. And I think that, it's unfortunate that I was that close-minded, because even if everything's not caused by Essure, that doesn't mean something isn't causing some issues, whether it be pain or bleeding or, something along those lines. But eventually Angie hung in there with me, and at least I began to be a little bit open to the concept of this, and eventually did my first case. And the first case that I ever did, I'll be perfectly honest, was a cut and pull. I cut the tube. This was probably 2.5 years ago. I cut the tube and I pulled it. And I will tell you that the entire time that I did that, it made me extremely nervous because the coils themselves are pretty fragile. And I think I got lucky on that one, although I can't honestly tell you if any pet fibers or anything like that got left behind, because we simply don't know. But the coils didn't at least fragment, and she didn't have a hysterectomy. Since that time, I've done probably, as of today, close to, if not more than 200 cases. And while probably 60% of those are hysterectomies, 40% of them are salpingectomies. So the reason that I stopped, I think initially, was because of that pregnancy that I had, or that my patient had. And it made me kind of start wondering, like, well, if she's one, there has to be more. And as I investigated, I just found out more and more, and I saw more and more women that were having problems. And then what happened, I think, over time is, as I started seeing more women with problems, and my practice sort of just started cascading with that, I just decided to, I think it didn't make sense to me to keep placing them. My experience, as I said right now, is I'm probably doing about 20 to 25 surgeries a month to remove these. I have women coming from mostly Texas, but now that word is kind of, getting out, Maryland, Arizona, Oklahoma, Louisiana, Ohio, many women are coming, and to try and accommodate that, we're really trying to get a lot of the prep work done ahead of time. Like, I had a lady today who sent me her records. I reviewed her records. She was kind enough to have the operative note, all the clinic notes, her x-ray recently, and I was able to review all that. And then I have the girls call her from the office, and we fill out a visit online. And then we get things scheduled through the insurance after we talk on the phone about what type of surgery we're going to do. And then I have you come out the day before the surgery. We do the pre-op. I do my exam. We do the surgery. And then you can, if I do the surgery on a Thursday, you can go home on a Sunday. And for those from out of town, there's a new app now called Medici that we can do the post-op exam on from a distance. So it's a HIPAA compliant. Obviously, if you're close enough to drive in, I would prefer that because I think it's better. But if you can't make it, then that's a good way to do it too, especially if everything's normal and you're not having any complications. So what exactly are we doing? First of all, and I think Penny Brow is really good at this on the main page. A lot of women are undergoing hysterectomies, and I think we get confused between the word partial and total. Medically, a partial to us means, to you all means uterus and not the ovaries. A total to us means uterus and cervix. But let's put that aside and let's look at the different types of hysterectomies. First of all is an abdominal hysterectomy. An abdominal hysterectomy is great if you need an abdominal hysterectomy. I would say out of the 200 that I've done, I've had maybe 1%. So most don't need to be done abdominally. If they do, there's a very good chance that the tubes will come out intact because they can very easily keep them attached to the uterus. A laparoscopic hysterectomy, which is the preferred method, I know Novoa, Ellis, Daron, we probably all agree on that point, that laparoscopic assisted, whether it's total laparoscopic or laparoscopic assisted vaginal, is a good approach because you can do everything abdominally, but then you only have the small incisions. The worst, in my opinion, and I think the other doctors would agree, and women still have this. As a matter of fact, I just did a surgery Thursday to correct a problem that with retained fragments at a woman that had a straight vaginal hysterectomy. And a straight vaginal hysterectomy is where we go in vaginally, and obviously the space is much smaller. And to see up inside the pelvic cavity vaginally is darn near impossible, especially up to the level of the tubes. And then you add on top of that, there's almost no way to keep the tubes physically attached to the uterus while we're doing the case, which means you have to cut through the coils and potentially leave fragments. And this is exactly what I've been seeing over and over and over again. I've seen it at least 3 times with women that have had vaginal hysterectomies, and you've seen it probably numerous times on the website. So anytime you're offered a straight vaginal hysterectomy, I would say no. I would go with a laparoscopic assisted or a Da Vinci or one of those types, or an abdominal best worst case scenario. Once you come up with the plan, and that's pretty straightforward. The other option for surgery, and this is not offered by everybody. I know Novoa probably doesn't do this, and that's perfectly fine and perfectly acceptable. But a lot of women undergo what's called a bilateral salpingectomy. The problem with the bilateral salpingectomy is multiple, and I really want you to clue into this, because you're going to ask your doctor how to remove the coils, and they're going to say, oh, we'll just do a bilateral salpingectomy. We're just going to remove your tubes. Great. Hey, doc, have you ever done one of these before? Of course we have, because we have. I mean, it's a very simple procedure. You cut the tube off at the level of the uterus and you remove it. The problem is with the coils in place, you don't want to cut the tube at the level of the uterus unless you know it's a grade 3. And even then, I don't think it's really that great of an option to do that. So there's 2 things you want to ask your doctor. 1, how many bilateral salpingectomies for Essure removals have you done? And they might give you a number. The second thing you want to follow up with is, how are you going to do it? And they're going to have to, at that point, tell you how they're going to do it. You can't fudge that. If they tell you they're going to cut the tube, get a second opinion. If they tell you they're going to cut the tube open and pull, get a second opinion. In my opinion, the only way to do this and really have the best results would be to find the tube, we free up the tube, and then you cut around the tube in a coring fashion, like you're coring down into an apple core, and you get it all until you get down into the endometrial cavity or the inside of the uterus, and then it all comes out in one block piece, and you pull it out through the trocar. The reason being is that then you have the least amount of fragments and you're not pulling. And if you think of the PET fibers that coat these Essure coils, the PET fibers are basically like a polyester. So if you're pulling this coil out and it straightens out, you could be potentially shredding these neurochemical fibers around, and that could cause problems. We don't know exactly. So why leave them in if you don't have to? So anytime the doctor tells you they're going to do a salpingectomy by cutting and pulling, or by strictly cutting the tube off at the level of the uterus, I personally would recommend getting another opinion. I would also challenge you to do this, and I know this is biased because I do it, but if you're going to have a salpingectomy, find somebody that's done them. Find somebody that you know that does them, even if it involves traveling. I know that sounds like you're spending a lot of money, but I can tell you, and the women can tell you that have had it done, you're going to spend a lot more money getting a revision or having a second or even a third surgery to find these pieces. I did a case last week of a lady that had a vaginal hysterectomy, which is the approach that I recommended not going with. She had 1.5 coils left inside of her pelvis. We found them by x-ray. I did the surgery where I went in with the cameras and I removed the remaining ovaries and tubes. So while she was still asleep, and after we'd removed the ovaries and tubes, we took an x-ray. Well, those pieces were still there. So what I found eventually, to make a long story short, after 18 intraoperative x-rays, the coils were embedded into the top of her vaginal cuff. We had to remove a section of the vagina, very small part. And the coil, one of her tubes, was also embedded in the vaginal cuff and up on the right side. And so, one, obviously that would cause pain. And two, you wouldn't have had to have that surgery in the first place had it been, or in the second place, if you'd had it, the correct procedure done in the first place. And so I just see a lot of women that have had 2-3 surgeries because these weren't removed right the first time. And I tell people online, you only get one shot to have this done the right way. And anybody can do a hysterectomy. If you find a doctor that's willing to do a hysterectomy with the tubes still attached to the uterus, 99.9% of the time, you're going to have probably a great outcome because most gynecologists can do that very well. It's when you have a doctor that doesn't want to leave the coils and tubes attached to the uterus, or wants to just remove the coils and tubes and really doesn't have an idea on how to do that. The point being is you don't want to be somebody's first case. I mean, obviously somebody had to be my first case. So Susan just asked, when you do laparoscopy, do you do morcellation? So two things. One would be hysterectomy. If you're doing a total laparoscopic hysterectomy, then the uterus and cervix come out through the vagina. If you have a doctor that tells you that they want to do a supracervical hysterectomy, that means cutting the uterus off at the level of the cervix, then the only way to get that uterus out is through an incision in the belly, and usually that means morcellation. So I don't like to leave the cervix just because of that point. If you're just removing the tubes intact with the coils in them, then you don't have to morcellate. Those tubes will come out right through one of the trocars that we put in the abdomen. Good question. So we talked about hysterectomy, we talked about salpingectomy. The other thing is insurance. I have a lot of women that talk about insurance and they're worried about coverage. And obviously it varies. I've had, like in my 200 cases, I know of one case that I had to call United Healthcare on because they denied it. Interestingly enough, I talked to the medical director at United, and he had heard of the surgeries that we've been doing, but he was kind of wondering why we were having to do them. And so I just told him about my experiences, and the surgery was approved. The other thing is most of y'all have pain and bleeding. Those are probably the two most common diagnoses that I see. Pain and bleeding are probably the number one and number two causes for a hysterectomy in the United States, other than fibroids, which can cause pain and bleeding. So most of the time your doctors have the correct diagnosis codes anyways, regardless of whether you have coils in or not. So it shouldn't be an issue. But the third diagnosis code that I use routinely is foreign body of the uterus, because that's exactly what this is. It's a retained foreign body and it's in the uterus. It might have been placed there on purpose, but it's still a foreign body. And that is a legitimate diagnosis code. You're not making anything up. It's there. Some women have other inflammatory issues, rashes, rheumatoid arthritis, scleroderma, other than the pain and the bleeding, dyspareunia, which is painful intercourse, weight loss, weight gain, nausea, vomiting. I mean, there are so many diagnosis codes that women are coming in with. But I would say the main biggies are what we already use and that we've been using for the 250,000 hysterectomies that are done in this country every year, and they get covered. So I don't like it when I hear that the doctor said it wouldn't be covered, because I haven't had that experience. And secondarily, and how do you say this and be politically correct? I hate it when women are told they can't have surgery because they're too overweight. It's ridiculous. It's rude. I mean, if you're 600 pounds or 700 pounds, I mean, and your life is at risk possibly. But most women that are, 200s, even early 300 pounds, we do those surgeries and women feel a lot better. Sometimes you can't lose the weight because you can't exercise, or you're eating poorly because you're depressed. I mean, there's a lot of reasons for this. And I think to just tell somebody that is ridiculous. In my procedure report, it says specimens removed bilateral tubes. So you'll see that in your operative note. You want to get the pathology report. The pathology report is going to tell you what is included. In your procedure report, it should say how they removed the tubes. Did they use a Essure device? Did they cut the tubes at the level of the uterus? Or did they cut into the uterus to remove the tube? If they're not saying that they cut into the uterus to remove the tube, then the chances are they just shaved it off at the uterus and removed it, and there might be still a piece of the coil still inside the uterus. Failed Essure tubal occlusion means you probably had your HSG test done 3 months post-op from having your Essure. They did the dye up into the tube, and the tube came out the end, meaning that the coil didn't close the tube. That would be my guess. And Amy was trying to help you out there. Sometimes women that have that issue, the tube just doesn't block. If you wait another 3 months, sometimes it will occlude itself. So sometimes it takes up to 6 months. So then the question is, what do we do? What's a proper, when you have a doctor that you're seeing that decides they want to do surgery on you, what's the proper workup? There are a lot of women out there that are having these surgeries done, and the workup is being done differently. A lot of doctors will just do an ultrasound. Now, let me tell you, I read about 600 ultrasounds every couple of months at my practice, and it's a decent way to tell where the coils are if you can see them easily. You can't tell if they're embedded, you can't tell if they're perforated, and you can't really tell if they're bunched up, and that's by ultrasound. So if the doctor's just doing an ultrasound, I think that's a bad idea. You want at least an X-ray to prove that they're in the pelvis. Some people would argue that you want to get an HSG because you want to know exactly where they are in the tubes. I think the HSG is a lot of radiation. I think if you know that the coils are in the pelvis, that you can tell once you get in there if they're in the tubes where they're supposed to be. Again, in my 200 cases, I've only had that fail on me one time. I had a lady that had a hysterectomy. I couldn't find the coils in her tubes. We x-rayed the uterus. One of the coils wasn't in there, and it actually was embedded in the fat pad by the uterus outside of the pelvis. And like I said, that's only happened to me one time. Sorry, somebody keeps calling me. It's only happened to me one time. And I think this is my 11-year-old. Hang on just a second. I'm going to text his mother and tell him. So what happens is you want to get an x-ray just for location. I don't like to, tell people that they need to have, the extended radiation from the HSG. So that's my approach. Not everybody's the same. I would say an HSG isn't a bad thing. It's a good way to locate them for sure, but it's painful, and you have the extra radiation from the dye. The other pre-ops that I do is I do a hormone panel. I check estrogen, progesterone, free and total testosterone, DHEA, thyroid, and vitamin D levels. And I do that because I find that 99%, I might have one woman every now and again that has a normal hormone panel. And the other thing, normal is a relative term. So if somebody tells you your hormones are normal, that doesn't mean that you feel good. Normal testosterone, for instance, is 0.2 to 2.0. Your testosterone could come back at 0.2, normal. But I could multiply that tenfold and make it 2.0, and you might feel a heck of a lot better. Your estrogen to progesterone ratios, I like to see those at about 10 to 1. Most women that I'm seeing are estrogen dominant, and their estrogen to progesterone ratio is around 200 to 1. That just doesn't feel good. It doesn't feel right. And so I check hormones because we don't know for sure. We know the PET chemical itself can be a neuroendocrine disruptor. I don't pretend to know if it can do that in the human body with the Essure coils, but I've been finding that hormones are pretty imbalanced. So I've been checking them. I check blood, and it's 99% of the time been covered. I have never had a problem with it not being covered. I call in a prescription, and we at least get you feeling better before we start the actual case. So then I have patients come in, we do the surgery. The surgery itself, I do mine Da Vinci, robotic assisted. Most women do very well, go back to work in sometimes 2 weeks, usually driving their car within 1 week. And what we then do is see them post-operatively, which is anywhere from 2 to 4 weeks. A post-op evaluation, and this is just me, but I think it's a good idea. A copy of the operative note, a copy of the pathology report, and a copy of any pictures. That just makes it easier for you to keep all your records in one place. If you do have attorneys requesting records, they'll get all that stuff for you, but I think it's just good for you just to have that stuff. And let me tell you this, even if the coils and the pictures look normal, it doesn't mean you're not going to feel better. It doesn't mean that just because the coils are in the tubes where they're supposed to be, that they're not causing pain. I've seen it too many times. I've had people ask me if it's placebo. Every surgery we do could have some sort of a placebo effect on the patient, but time and time again, almost across the board, women feel better. Obviously, not everybody does. And there's different degrees of feeling better, but I would say most 8 out of 9 or 8 to 9 out of 10 feel significant improvement. So any questions so far? If you have what I would say is if somebody just asked can you have a traditional tubal if you've had the Essure? Well, you wouldn't need a tubal if you've had the Essure, obviously. But if you have the coils removed because you want to have a tubal reversal, where you want to get pregnant, then yeah, you can have the tubal ligation. Do you offer traditional? That's all I do. So I don't do Essure, obviously. If somebody wants permanent sterilization, I do the basic tubal occlusion where I put the cautery on the tubes and I burn them. I don't put in Filshie clips. I don't put in Hoka clips, and I don't put in fallope rings. I just use the traditional approach. Janice, I'm in Louisiana and have bilateral and want to have a bilateral self-injecting. What's the best way to get the ball rolling? I'll put in Amber's name. Amber is my nurse, and her phone number is 512-533-4141. We'll get the ball rolling on your insurance and figuring out what they cover. And what I'll probably end up doing for your out-of-towners is I like to have your records, everything you can get for me. If you don't have everything I need, then I'll order it. If I'll order an x-ray or whatever. And then I'll have one of my girls from the office call you, and we'll over the phone. We'll do your intake so we can get your stuff into our electronic medical record system, and then we'll get things scheduled and we'll get you out for the pre-op evaluation and the surgery. I don't usually order a pre-tubal ligation hormone panel on women. I don't, unless they're having issues where they just feel out of whack. Somebody mentioned brain fog. The brain fog, I don't know what that is. I don't even know if we know what it is when women even have menopause or a hormonal imbalance. But I would say that I do hear that a lot from women. I've had women have that go completely away. Again, I can't explain why, or I can't even explain what it is, but I do see that a lot. When you're doing Essure, how often would you need to use 2 kits on a patient? You know, that's impossible to say. And, you know, I'm not there to evaluate that. Sometimes when you can't, if you get the one side in correctly, and for some reason the other device that's going in the other side isn't working properly or won't go in, you open a second package. I mean, it's happened. It happens to everybody. I think that it's, you know, it's definitely within the realm of okay to try a second pack if you're having issues and you really are trying to get it in. But again, impossible to say unless you have the medical records and you're reviewing the case. In your opinion, does Essure trigger autoimmune disease? You know, that's a difficult question to answer. I've seen some pretty crazy things. I've seen a woman that had 5 medications for rheumatoid arthritis who went down to 1. I have seen rashes go away immediately within days of having the surgery that were there for years before. I guess the way I look at it is this. We know that the Essure coils are supposed to cause an inflammatory response and fibrosis. That's how they work. That's how they crimp and close the tube. If you have a device that's supposed to cause an inflammatory process and you have a patient that might be predisposed to an inflammatory process, are we adding gasoline to the fire? I don't know. It'd be something that I hope someday we can look at and maybe do a little research on. I think it's a good question, and I think it's something that is worth looking into. Are there other risks post-hysterectomy to be concerned about bladder prolapse? You know, that's a good question, Donna. I get it all the time. There's 3 levels of support with the vagina. One is the introitus, or the opening. There's musculature there. The second layer is the level of the cervix, and the third level is the layer of the ligaments above the cervix, cardinal ligaments and uterosacral ligaments. There are multiple things that lead to prolapse and not just one. It's kind of like, you know, other diseases like cancer where you can't just say one thing caused it. Bladder prolapse, vaginal prolapse, rectal prolapse is a combination of things. One is vaginal births, baby size, genetics, smoking, issues with being morbidly obese, increased abdominal pressures over and over again for women that might cough a lot, or women that have jobs where they're lifting heavy things. I had a lady who had something like that because she pushed big carts in the mail rooms at the Postal Service where she had to push really hard to get the carts going. I had a woman who cleaned hotel rooms and she had to lift the mattresses very frequently. So that kind of stuff can lead to it. So it's not just one thing. Surgery is one of them. Usually, if you have had no family history of a prolapse, chances of having a significant bladder prolapse after a hysterectomy are probably pretty slim. I would guess in the order of 1 in 1,000 or somewhere around there. Have you reached out to the women who you inserted the Essure product to advocate for their health rights now? You know, I'm on the Arizona website, and I've actually spoken to a couple of the women that I've placed coils in, and I've tried to find them surgeons out there that will help them remove the coils. You know, not everybody that had the Essure place is having problems, or at least knows that the problems that they're having might be caused by the Essure. But if somebody called me, I would certainly, you know, tell them of my experience and tell them that there's physicians hopefully in that area that could help them with removal. How do you handle the hormone panel for out-of-town patients? Well, if if I'm your physician, and if you come in and I see you and you live in Cincinnati and you want to have your hormones tested, I can fax a lab slip order to your lab, and we just go from there. I can prescribe medications for up to 12 months in the state of Arizona, outside the state, as long as I've seen you once a year. And we can touch bases with you over the phone. Are doctors required to update their Essure certification? There is absolutely nothing that I'm aware of that's a certifying process to put the Essure in, because it's hysteroscopy and it's something that we do become proficient in hysteroscopy during our residencies. And I don't know anything about the changes that have been made in the device. I'm sure the ladies on the Essure page could help you with that. And this is Jackie said, I had the procedure done 15 years ago and never once did I link the health issues with the coils. And, and that's what I'm saying is there's a lot of women out there that they may not know that the pain that they're having could be caused by the coils. But if you think about it, and I've used this analogy before, if a male patient had this coil in his vas deferens, which is the coil or the tube that connects the testicle to the urethra, and he came in and he said, "Hey doc, this coil that you put in me is really hurting me. I'm not able to work. I can't do anything with my kids because it hurts bad." Well, what the doctor could do is go up to that testicle and just kind of pinch the coil, and he would say, "Ow." And we would say, "Oh yeah, that's obviously the cause of your pain." The problem is with women, we can't go up and pinch the tube, and we can't hardly even feel the tube or tell what's going on with the tube. So it makes it a little more difficult to assess that. And I don't think that the doctors in general wouldn't want to help had they could, but it's a difficult process to figure out. There is another webinar recorded for the 28th. I'm just going to do kind of the same thing. We're going to just kind of chat. I am recording this one and it will be available for replay and permanent recording. In order to do that, I had to pay quite a bit of money to the company that runs this webinar, GM. So what I'm going to do is I'm going to offer it for $5, but I'm going to include a transcript of the talk, and I'm going to include my removal process and what I do. So if you want to take it to your doctor, you can. I hate to charge for it, but it's not cheap. So there's no way to know if this causes extreme fatigue, although I will tell you that is one of the things that I have seen. I have a lot of patients who have had extreme fatigue and they tend to feel better after they have removal. But again, there might be some patients out there that have extreme fatigue that have them removed that don't. Now, there is no 100% in anything when it's involved in healthcare and in life in general. And I just, like to talk to my patients. I think part of the thing is just discussing things and being heard and being recognized. Have you found that hormone levels balance out after Essure removal? What I've been doing recently is women that have been on the hormones for a few weeks prior to the hysterectomy call me and they want to know if they need to stay on their hormones because they're feeling so much better. Probably in the last year, I've been telling them, no, if you're feeling great, don't stay on the hormone. You could be partially feeling better because you're on the hormones, but it could be also that you're just feeling better. And so we stop the hormones. Maybe 10% of the time I've had women call back and they want to restart things or, take a look at things again. So I would say that in my experience, some women do experience that where things kind of balance back out. There is no way to remove the coils vaginally. It's not recommended even by the manufacturer. The only time it's okayed, even by the manufacturer, to remove the coils vaginally or through the uterus is during the insertion. So if they put the coils in and there's too many spirals, like more than 16 spirals that they can see coming out of the tube, then it's okay to remove it vaginally. Other than that, there is no recommended way to remove them vaginally, and it should not be done. You love me. Thank you. Actually, in the last 3 years, I've really found a lot of joy in doing this. It's been very rewarding. And I think that, you deliver babies and that's very rewarding, but I'll tell you, doing something like this that's kind of not widely accepted yet, but seeing that it's helping a lot of women, and wishing that I could get to some of you before you have these other cases done where there might be fragments or other things left behind. I will be presenting one of my cases video wise to the Society of Robotic Surgery in hopes to just reach more doctors. And I'm hoping that more doctors are willing to undergo the training. I have one guy at my office that is very interested in removing them. And I've had a couple of others that have approached me. So hopefully, as time goes on, I think we'll start seeing physicians that are trained in removal. And that's really the main thing. If we do something, if we put in an IUD, we know how to take it out. We know exactly how to remove it. And that's great. We should have the same thing with a coil. We should have the same thing with, a surgical clip or, any of that stuff. It should be something that we can remove. The problem with the Essure coils is that they're very difficult to remove. They're easy to remove for a hysterectomy, but they're extremely difficult to remove by just a salpingectomy. It's sometimes more difficult than doing the hysterectomy, but it is done. It can be done, and it can be done right. Why do you think so many doctors are unwilling to help? I really can't say. I don't know. I mean, I know I was there 3 years ago, and things change. Opinions change. I honestly believe most doctors want to help their patients, and I don't think that we willingly want to hurt people and not help people. Maybe they don't know how to help, and that's not necessarily right or wrong. It's just the truth. But I don't know. I mean, I think you have to advocate for yourselves, and you have to find somebody, and you will. There's doctors around the country that are trying to help. I know them personally. I've spoken to some of them, and some of them are friends, but it's still not very many. But I think that will change over time. Why are doctors so resistant that it causes hormone issues? My implanting doctor refuses to believe the Essure can cause hormone problems because we don't know for sure. But even if it didn't, even if you didn't have Essure, some doctors are reluctant to say that hormones are the cause of anything and that it's just your age. Get used to it. And I think those are probably the same type of doctors. I don't think that anybody's necessarily saying it can't be this or it can't be that, but they might not just buy into the whole hormone potential anyways. And that's unfortunate. You mentioned you check vitamin D before removing. Can you explain a little bit about the vitamin level with Essure? Honestly, 95% of the population is vitamin D deficient. So I don't necessarily think the Essure is causing a vitamin D deficiency. It'd be hard to prove that because you'd have to get a vitamin D level before, and then you'd have to get a vitamin D level after and see that it's significantly changed. But majority of us are low, including myself. And so when I get hormones, I just automatically check for vitamin D. And most people that I see, I have them taking 5,000 units a day, pretty much forever. And even then, it doesn't bump the levels up, hugely. But I think most of us would benefit from being on some vitamin D. I may have a coil left in my uterus after a bilateral salpingectomy, but I really don't want a hysterectomy. Do I have options other than a hysterectomy? Why also do I keep getting repeat cysts? Number one, the only way to know if you have a coil left is to do an X-ray. So that would be the first step. As far as the repeat cysts, the cysts, every woman makes a cyst every month when she has a period. That's just physiology. That's just how we survive as a species. And unfortunately, some of those cysts are painful. But I think that, that's something that you should probably talk to your doctor about. And obviously, what I'm saying to y'all tonight is not, I can't give you medical advice. I'm just sharing my experiences. And while I'd love to have you all on a big jet fly out here and not for just me, but for y'all to just kind of get together, nothing's more rewarding for me than the next day seeing the 4 or 5 patients that I operated on Thursday in each other's rooms at the hospital on Friday morning. Because I think part of this is just support and, sharing stories and understanding that, you're not alone, and things of that nature. Have I had backlash from my peers? I'm not going to answer that. Sorry. I think that, we're all entitled to our opinions. We're all, human beings, and we're all kind of on this ride, and, we're all just trying to figure things out. And I would say that I'm happy with the decisions that I've made for my patients. Even at the time, when I was doing the coils, putting them in, I was doing what I thought was right. I was, but over time I changed my mind. And I think that anybody can do that, and in any job. And but the main thing here is to just share, support, be there for each other, and learn from each other. And the good news is there is a big study that's moving forward outside of the company that is going to be a retrospective study. So we're going to look at a lot of cases that have been done before, and I'm hoping that we're going to review procedures, how they were done, what the results were. I'm currently reviewing the 200 records that I have, to try and help and see if we're seeing, great results. The problem is, obviously, there will be naysayers and there will be people that discount it. But I do know of some pretty big time docs that were involved in the initial research with hysteroscopic sterilization that now only do removals in different countries. And so, it's neither here nor there, but I think that just like any surgery, whenever you're putting something into somebody's body, there can be complications. It's just the way that it is. What are the biggest problems women have after hysterectomy? Are you talking most common problems or the most serious problems? Because obviously more common things are going to be like wound site infections. Sometimes you can have pain after sex for a few weeks when you start again. Some women can have prolapse, as we talked, but it's rare. You can have a bigger problem. Common, like I said, infection is probably number one. Pain, spotting from the vagina for a couple of 3 months afterwards. Most of the time, though, if your pain is rather significant, you feel better. I mean, if that's not a risk, but those are risks that you'll talk to your doctor about. And we all know the risks, and we'll go over those with you. As far as what do I do when I have talked to many different doctors about my discomfort and declining health, and they tell me it's all in my head? Keep looking. I mean, I'm sure eventually you'll find somebody, especially if you go to the admins on the Essure Problems website. They can usually help you find somebody in your area that's at least willing to listen. It doesn't mean that they know how to remove them. And that's the one thing I want to touch on too, is just because a doctor's on the list doesn't mean they have experience removing. It means they're open to helping. And that's a little bit of a difference, especially if you're having self-injectomy. Go to somebody that's done it before. Go to somebody that does it the right way, and go to somebody that's going to work it up and follow it up appropriately. I think we're going on about 50 minutes, and I don't want to bore everybody to complete tears. I'm trying to think of anything else that I might have. I think I've covered most of the stuff that I wanted to. Like I said, we'll definitely record this. Some ladies in Canada are asking, what can we do to alleviate pain and swelling while waiting for surgery? I have a lot of patients that are waiting for surgery in December, and it's just trying to keep them comfortable until I can get them into the operating room. And sometimes that means pain medications and other things, acupuncture, yoga, things like that. Women who have hysterectomies run higher health risks. Not that I'm aware of. I mean, there's no increased risks of uterine cancer because the uterus is gone. I'm not sure what you're meaning, what type of health risk. Sometimes if they remove the ovaries, yeah, you could have an increased risk of osteoporosis because you're going to have menopause. But overall, the uterus itself, there wouldn't be any health risks by having the uterus removed. Any last questions before we wrap things up? I'm glad y'all were able to make it. I know that it's kind of a weird time of night, but I just wanted to make sure that I wasn't going to get interrupted. And my wife was kind enough to corral the kids for me. Of course, even though she was doing that, somebody still used the printer while I was sitting here to print some things out. So you never can be too alone. So again, I'm in Austin. If you guys have any questions, Amber, my nurse, or Angela, I'll put both their names down because Angela gets all upset when I don't include her. And if she's on here, that was a joke. Amber and Angela, 512-533-4141. I'd love to help y'all if I can. Just let me know. And we'll put this on Evergreen if y'all want to have a copy of it. I'm hopeful that I might even be able to put a copy of my actual video of a procedure so you guys can take that to your doctors. But rather than do that, they may not watch it. I might just put an actual Google Doc of what I do, and that would be part of the $5 so I can help cover some of these costs. But thank you all for being here. Thank you for showing up and taking the time away from your families. And I'll be around on the stratosphere. Bye.